This is extraordinarily good. Thank you very much, Jason. And certainly you took away many of the comments I may have.
That's why I wanted to go first.
But I do have one. And that's all I have actually to say, that there might be a role for ruxolitinib or JAK inhibitors beyond strictly defined patients that are resistant or intolerant to hydroxyurea. And this actually has been brought up in the discussion. So I have only a few extra slides that you haven't seen. Many of these have already been shown, but what you will appreciate that you can actually infer different conclusions by looking at those. So why we treat patients with PV? We talked a lot about controlling the numbers, decreasing this thrombotic risk, and making people live longer without morbidity and mortality related to that. But these are actually the goals that are fully published many years ago, and we all agreed that we should not just look at the thrombotic or bleeding complications, but do all these other things. And what was new in that aspect was what is in the red square here, to control systemic symptoms. Because we learn over time it's not just about numbers, it's about the person, and the person needs to enjoy life fully. So the goal is to control the symptoms. So what do we do about this? This is just a regular summary from any textbook, and again, it says here that we should control the symptomatic progressive splenomegaly and severe disease-related symptoms. So we modify our goals in 2011 to include control of the symptoms. And when we look at the diagnostic or clinical hematological response criteria, which we apply in the studies these days, this is hard to apply in everyday clinical management, but these are expert opinion-derived guidelines how to assess the response in polycythemia vera. We again looked and said we should not have any disease-related symptoms if the patient is responding. That's one of the factors. So using this criteria, and that was presented, Jason outlined this in much detail, the CR rate, complete response rate, is only a quarter, right? Only a quarter of patients would fulfill normalization of blood cell count, spleen, and symptoms. Just a quarter. Majority of patients have a partial response. They are doing okay, but they're not doing well that we would like them to do. By our expert opinion, that would include all these 5 factors. That would be white cells, red blood cells, platelets, spleen, and symptoms. Now, then we came together and we said, okay, now we want to define this group of patients. What is the resistance and intolerance? And we said this is going to be by the significance. First would be, okay, we can achieve the phlebotomy, with the phlebotomy, control of hematocrit, with a decent dose of hydroxyurea. Then we cannot control platelets or white cells. Target number 3 would be spleen. And then we go to the toxicities. So upper 3 parts are resistance, the lower 2 parts are intolerance to hydrea. Something is missing. Symptoms. We don't have anything here that says that uncontrolled symptoms are a sign of a resistance to hydroxyurea, but we yet want them to be gone, and our goal of therapy is control of the symptoms, and the response criteria says they should not be there, no symptoms. And we assess the utility of hydrea in a retrospective way using that criteria, and said only a quarter of patients have complete control of everything that we want. So we fail here in identifying a symptom control as a failure to therapy with hydroxyurea. Now, you showed this already, and we know that this resistance is bad for the patients, right? If we can control the factors, then their outcome is bad, both in the transformation and in the survival overall. So it's not a trivial question. What is the definition of an intolerance or resistance in particular? Now, let's go back to the symptoms, and that was shown before. These patients are very symptomatic. This is from Dr. Ruben Mesa's effort widespread global effort to analyze the quality of life of the patients, not just with PV, but ET, PV, and myelofibrosis. This is here explained which one is which. The red one is data related to patients with polycythemia vera, and this gives us a summary of what we already know, that these patients are largely symptomatic and they suffer from many different problems, as patients with PV or ET do. Now, sub-analysis of this related to exposure to hydrea is very interesting. Whether patient is or is it not hydroxyurea failure does not appear to be affecting the notion that patients still have symptoms. They are still symptomatic, and whether you call it failure or not does not appear to be a difference. So we did not account here properly for control of the symptoms in our designation who is doing well on hydrea and who is not doing well on hydroxyurea. And now, as was shown before, we have a medication that improves symptoms a lot. Now, I don't have a slide, but I appreciate you showing the relief study results, where in a double dummy blinded way, the patients were randomized between hydroxyurea continuation or switching to ruxolitinib. But I do agree with the conclusions of the paper that perhaps if the larger study was done, not just 55 patients on each arm, that trend for improvement would become probably significant. We also appreciate that there is a placebo effect in myeloproliferative neoplasms. There's no doubt about it. And there are studies that are designed to offset that problem. So that study was not statistically significant, but had a trend, and the issue of a proper design, a number of patients may have contributed to lack of statistical significance. On the other hand, there is clear evidence here in the response study that symptomatic improvement by and large happens in these patients. And one of the questions was at the beginning, how many patients have control of itching? 95% of the patients have control of the itching, which usually happens within a couple of weeks. So now we have this option of ruxolitinib for patients with inadequate response or intolerance to hydroxyurea, in addition to all the other options that we have discussed. And interferon again and hydrea are equally available for frontline or the second line. And therefore, in my assessment of how would we assign patients to different therapies, I go by this particular algorithm, which is kind of a guideline again. So I would assess the risk of thrombosis, but also symptoms. And then treat patients with phlebotomy and low-dose aspirin, unless the platelet number is very high, where there is a von Willebrand factor deficiency, and then decide on the need to do site reduction based on the risk and symptoms. And then if there is no need for site reduction, as you can see, monitor those symptoms, vascular events, and progression, because vascular event obviously would make people high risk. And if that worsens any of those, including symptoms, then we would switch to site reduction, which is on the right side, with hydroxyurea or interferon as the first-line choices. And then if there is a failure defined by worsening symptoms, vascular events, which are again not even listed in the definition of the resistance, progression, or by standard hydroxyurea-resistant or intolerance defined factors, then I would consider ruxolitinib or interferon if the hydrea was only prior cytoreductive therapy. So I would broaden somewhat my inclusion for therapy with the JAK inhibitors based on the symptomatic control as well as defined blood cell count and the spleen. That is the only factor that I would argue with you. I give up on all the others. So thank you very much.